Hello and welcome to Lupus Nephritis and Kidney Disease, a comprehensive review. I'm Annika Hazlitt, a member of the Board of Directors of Kaleidoscope Fighting Lupus, and your host. Lupus nephritis is when lupus attacks the kidneys. It occurs in up to half of all people living with lupus, and if poorly controlled, can lead to kidney damage and even failure. So, what do you need to know about this potentially life-threatening condition? I'd say as much as you can. Kaleidoscope reached out to Dr. Tiffany Wong, a clinical nephrologist with Kaiser Permanente Moanalua Medical Center in Honolulu, Hawaii, for this video. We asked her to share her extensive knowledge about this difficult to navigate complex disease. What you're about to see is a fantastic video. Dr. Wong takes us from the basics of kidney anatomy to the symptoms, diagnosis, and treatment options of lupus nephritis, including the ins and outs of kidney transplants when those are necessary. As you can tell, we are very excited about this video. Before we hear from Dr. Wong, I'd like to thank our presenting sponsor, Aurinia Pharmaceuticals, for their generous support in making this presentation and the rest of our Living Well with LN video series possible. I would also like to thank our community sponsors, Blue Eyed Crow Studio, Tin Rocket, 7 Minute Cinemas, and Due North Studios for their continued support. Now, let's hear from Dr. Wong.
Hi, my name is Dr. Wong and I am a nephrologist, which is just a fancy name for a kidney doctor. My goal for this talk is to give you a broad overview of how lupus affects the kidneys, how we manage lupus kidney disease, and what I wish all lupus patients with kidney disease would know. Most of us have 2 kidneys, but some people are born with only 1 kidney. Your kidneys are located in the mid-upper back. Our kidneys are the filters of our body. They filter the blood to make urine, which helps get rid of toxins and fluids. Our kidneys also help to manage things like blood pressure, blood count. They make a hormone to tell our bone marrow to make red blood cells, and our bone health by managing things like calcium, phosphorus, and vitamin D. The kidneys do a lot. To check the level of kidney function, we check a lab called creatinine. Creatinine comes from muscle breakdown, which is normal. If your kidneys are not working or not filtering as well, the creatinine level goes up. It is an inverse relationship. The higher the creatinine level, the worse the percent kidney function. We usually think of good kidney function as anything over 60% and very bad kidney function as less than 20%. We divide up kidney disease into 5 stages based on the percent kidney function. In stage 1, kidney function is over 90%. In stage 5, kidney function is less than 15%. Stage 5 is also referred to as kidney failure. We will talk about how we manage kidney failure later. We also gauge kidney health by checking how much albumin is in the urine. Albumin is a specific type of protein. Normally, there should be a minimal amount of protein or albumin in the urine. If there is a large amount of protein or albumin in the urine, this indicates there is some kidney damage. The more albumin or protein there is in the urine, the worse the kidney damage. Lupus can affect lots of different parts of the body, including your kidneys. About half of patients with lupus will develop lupus kidney disease, and about 10% of those patients will progress to end-stage kidney disease or kidney failure. Lupus kidney disease can sometimes be the first sign of lupus. Lupus kidney disease can present with an abnormal urine test. Normally, there should not be any protein or blood in the urine. The presence of blood and/or protein in the urine can mean there is inflammation going on in the kidney on a microscopic level. When there is a lot of protein in the urine, you may notice your urine looks foamy or has lots of bubbles in it. You will not notice any changes to your urine when there is a microscopic amount of blood, but if there is lots of blood in the urine, it will be pink or reddish colored. Lupus kidney disease can present with high blood pressure, and unfortunately, sometimes high blood pressure can present with no symptoms. When blood pressure is dangerously high, you may have a headache, blurred vision, pain in the chest, or trouble breathing. Ideally, your blood pressure should be less than 130/80. Sometimes, lupus kidney disease can just present with a high creatinine detected on routine labs. If we are worried about lupus kidney disease, we can start by checking several different labs, including a urine analysis to check for microscopic blood and protein, creatinine to check the kidney function, urine albumin to creatinine ratio, and urine protein to creatinine ratio to quantify the amount of albumin or protein in the urine. Some doctors may even make you do a 24-hour urine collection to get a more accurate quantity. We'll also check C3 and C4, which are generalized markers of inflammation. In lupus kidney disease, these levels are low. And anti-double-stranded DNA. This level tends to be high in lupus kidney disease. While the labs can make us suspicious that you may have lupus kidney disease, the only way to be sure is to get a kidney biopsy. A kidney biopsy is a procedure where we take a small sample of your kidney tissue to look at underneath the microscope. It sounds much scarier than it is. This procedure is usually a same-day procedure, meaning you don't have to stay overnight in the hospital. This is usually done by an interventional radiologist or a nephrologist. The procedure itself takes seconds. It is the setting up and monitoring that takes time. They sterilize the area to minimize the risk of infection. They numb the area to minimize discomfort. The kidney itself has no nerves. You should only feel a little bit of pressure during the biopsy. They typically use an ultrasound or CT scanner to make sure they know exactly where the needle is going. The needle itself is like a clicky pen. They line up the needle to right on top of the kidney and it grabs a tiny piece of kidney tissue, no larger than the length of your pinky nail. They usually take several samples of kidney tissue to make sure there is enough tissue to make a diagnosis. This tissue is then sent to a pathologist to look at underneath the microscope. It can sometimes take up to a few days before the kidney biopsy results are finalized. The main risk of a kidney biopsy is bleeding, so you are usually monitored for a bit after the procedure. A kidney biopsy is necessary because it's the only way to figure out what class of lupus kidney disease you may have. We treat the different classes of lupus kidney disease with different therapies. Lupus kidney disease is divided up into 6 classes, but you can have overlap, meaning the biopsy can show more than one class. Classes 1 and 2 mean there is minimal inflammation in the kidney from lupus. Because there is minimal inflammation, we do not use strong immunosuppressive medications to lower your immune system. If we find class 3 or 4, that means there is a substantial amount of inflammation. In this case, we do need to use strong immunosuppressive medications to reduce the inflammation before the inflammation progresses to scarring, which can eventually result in loss of kidney function and eventual kidney failure. Nowadays, there are several options for treating lupus kidney disease classes 3 or 4. We call initial treatment induction therapy. All treatment options are usually given with steroids such as prednisone. Treatment can be as short as 3 months or as long as 1 year. We track response to treatment by following the urine protein levels and look for improvement or stabilization of kidney function. If remission is achieved, we transition to maintenance therapy. Class 5 does not have significant inflammation, but there is microscopic damage seen that causes the kidney to spill lots of protein in the urine, which can lead to scarring in the kidney over time. Class 6 means there is unfortunately an extreme level of scarring in the kidney that is irreversible from prior inflammation or progression of classes 3, 4, and 5. If there is a mix of classes, but class 3 or 4 is present, we do need to treat with immunosuppression. These medications treat high blood pressure and lower protein levels in the urine. Lupus kidney disease can flare or relapse over time. Flares or relapses can happen in up to 1/3 to over 1/2 of patients. If a flare or relapse happens, we usually intensify the maintenance medications or use the induction medication again. Medications like hydroxychloroquine try to reduce the risk of flares or relapses. However, long-term use of hydroxychloroquine can cause eye disease, so it is important to get your eyes routinely checked while taking hydroxychloroquine. Lupus kidney disease can progress to kidney failure. About 10% of patients with lupus kidney disease will progress to end-stage kidney disease. If you develop kidney failure, there are several options. Dialysis is one option for management of kidney failure. Think of dialysis like kidney life support. It is not fun nor easy, but it can help you to continue your life as best as possible. The decision about when it is time to start dialysis depends on your labs and how you are feeling. There is no absolute % kidney function with which we must start dialysis. Realistically, most patients will need to start when their kidney function is in the single digits. The labs that we worry about are things like high potassium, low bicarbonate, high phosphorus. These are all signs that the kidney is not filtering out the things we need it to. The signs and symptoms that are worrisome for buildup of too many toxins are feeling really tired, no appetite, nausea, vomiting, funky metallic taste in your mouth, unintentional weight loss, severe leg swelling and shortness of breath, difficulty sleeping, difficulty concentrating, and poor mood. There are two main kinds of dialysis. One is called hemodialysis. Hemodialysis involves a machine that cleans your blood and removes extra fluids. Hemodialysis can be done at a center close to your home, typically on a schedule of 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, for about 4 hours per session. Hemodialysis can also be done at home, typically 4 to 6 times per week, about 3-ish hours per session. The machine used for home dialysis is different than the machine used in the dialysis center. The benefit of doing dialysis at home more frequently is that you can get better control of things like fluids, blood pressure, and phosphorus, which is better for your heart and your overall health. To be able to access the blood, most patients have a dialysis shunt in their arm called a fistula or graft. These dialysis shunts are placed by vascular surgeons. A fistula is formed by strengthening your natural vein with a same-day surgical procedure. You will have a small scar either by the wrist or above your elbow. If your veins are very small, the surgeon may recommend placing a graft or a fake vein. We usually ask the surgeon to place the fistula or graft way before you need to start dialysis because it can take weeks to months for the dialysis shunt to fully mature and be ready for use. We try our best to avoid dialysis catheters. These are like very large IVs that typically poke out of your chest. Dialysis catheters are very high risk for infection of the blood and the heart. In the dialysis unit, the technicians or nurses place the needles in the fistula or graft to access the blood and connect you to the machine. With home dialysis, we train and teach you to poke the needles yourself. Some patients use a technique called buttonhole, where they poke the same place each time to make it easier. The other dialysis option is called peritoneal dialysis. Peritoneal dialysis is done at home every day by you. We train you how to do it and give you all the supplies. With peritoneal dialysis, there is no blood involved, so this is a great option if you are afraid of needles and blood. You would have a catheter poking out of your belly. Clean dialysate fluid is placed into the belly, and the belly's natural lining, called the peritoneum, helps to remove the toxins. After the fluid sits for a bit, we drain the dirty fluid. This exchange is done several times. Peritoneal dialysis can be done manually, meaning you connect the belly catheter to a bag of clean dialysate fluid and let it drain in by gravity, and then let it drain out by gravity when you're done. Peritoneal dialysis can also be done with a machine called a cycler. Most patients connect to the cycler at night, and the exchanges or treatment happens overnight while they are sleeping. If your lupus kidney disease progresses to end-stage kidney disease, you can be eligible for kidney transplant. You are eligible to be listed for kidney transplant when your kidney function is less than 20%. Most patients will start dialysis when their kidney function is in the single digits, so this means you can get put on the kidney transplant list even before you might need dialysis. Kidney transplants are done by transplant centers. Not every single hospital is a transplant center. There are 2 kinds of kidney transplants. You can get a kidney from someone who is living, what we call a living donor, or someone who has passed away, what we call a deceased donor. To be eligible for kidney transplant, you have to be somewhat healthy. You cannot have active cancer, or if you had cancer, the cancer had to be treated, you are in remission, or your oncologist has said it is a very low-risk cancer. If you have things like diabetes, your diabetes must be well controlled. If you have high blood pressure, your blood pressure must be well controlled. If you have mental health issues like depression or anxiety, these must be stable, meaning taking medications or following with a mental health specialist. You have to be able to exercise a fair amount, and there's usually a weight target or BMI goal. You cannot smoke or use illegal drugs. If you do have a prescription for marijuana in states where it is legal, many transplant centers will discourage smoking marijuana because of the increased risk of lung infections, and marijuana can interact with some of the transplant medications. You must be an A+ patient. This means you have to be taking all of your prescribed medications regularly, know your medication names and doses, and come to all of your doctor's appointments. If you are on dialysis, you must show up for every treatment and not cut your treatment time short. Lastly, you have to have a support system. This is a tough process to go through and to recover from. So most transplant centers need you to show you have a person who is willing to take you to appointments, labs, and be there with you while you recover. I know this sounds like a lot the transplant center is asking of you, but the transplant center is trying to make sure you are healthy enough to undergo a major surgery and withstand medications that heavily lower your immune system and come with risks. As of 2023, things like the artificial kidney and animal kidneys, like those from pigs, are not available for the general population. They are still very much in the research phases. If a transplant center decides you are a good candidate, you get placed on the transplant waiting list. Depending on where you live, the waitlist time can vary a lot. In places like New York and California, the waitlist time can be many years, sometimes upwards of 7 to 9 years. In places like Florida and the Midwest, the waitlist time can be much shorter. You are allowed to put yourself on different waitlists as long as they are in different transplant geographical regions, what we call multi-listing. For example, if you lived in the Northeast, you could get listed at a center in New York City, Philadelphia, and Baltimore. If you are not yet on dialysis, the first center you are listed at will have the longest accrued wait time. You are allowed to transfer this wait time if you want. For example, if you waitlisted in New York City, but then realized a transplant center in Philadelphia had a shorter wait list, you can transfer your time from New York City to Philadelphia. If you are on dialysis, you get credit on the wait list back to day 1 of dialysis. For example, if you've been on dialysis since January 2020 and you were to be put on the wait list in June 2023, you'll start off with already almost 3.5 years accumulated. If you are on the list but are sick or a new medical issue develops, a transplant center may place you as status 7. This means you stay on the list, but you cannot get any active kidney offers until you are reactivated. On average, a deceased donor kidney transplant lasts about 10 years, but this can be much longer depending on how well you take care of the kidney. The best option for kidney transplant, if possible, is to get a kidney from a living donor. A kidney from a living donor tends to do better and last longer, about 15 to 20 years compared to 10 years for a deceased donor. Once a transplant program has said you are a good candidate for a kidney transplant, anyone is allowed to get evaluated as a potential living donor for you. This person does not need to be related to or the same blood type. There are programs such as the National Kidney Registry or Paired Kidney Exchange Program, where as long as you have a healthy donor that was deemed not a good match for you, they will find you a donor that is a better match. Transplant programs will not take a kidney from a donor unless they feel confident that this patient is healthy enough to donate and has a very low risk of developing kidney disease themselves in the future. They undergo extensive testing, sometimes even more testing than you may have to. I have often heard from patients that they are nervous, scared, or embarrassed to ask others to donate their kidney. I tell my patients to ask a loved one to be their kidney transplant advocate, to be the one to ask others on your behalf. I also strongly urge patients to ask anyone and everyone through places like work, school, church, social media, etc. You never know who may step forward as a potential donor. Lastly, I am honest with patients that working up a donor is not fast. It can take sometimes upwards of 6 to 12 months to get a donor evaluated. However, this is much faster than waiting several years on the wait list. When you finally reach the top of the transplant wait list and the transplant center finds a good kidney match for you, you will get a call to come into the transplant center. This can happen at any time, even in the middle of the night. If you are getting a kidney from a living donor, this surgery is scheduled at a time that works best for you and the donor. The transplant surgery takes a few hours and you will be in the hospital for a few days. You will follow up with your transplant team very frequently in the first month after transplant, and the follow-up visits and labs will eventually be spaced out over time. Fun fact, most of the time the surgeon's leaving your kidneys, so after transplant surgery, you actually end up with 3 kidneys. The kidney tends to be placed in the right or left lower belly. At the time of transplant, you will get very strong medications to suppress your immune system to prevent your body from rejecting the kidney. This means that for the first several months after transplant, you are very high risk for getting infections. Remember, kidney transplant is a treatment for kidney failure, not a cure. This means that you will be on transplant medications for the rest of your life. If you stop or adjust your medications on your own, you risk rejecting the kidney and ending back up in kidney failure and on dialysis. Most transplant centers use a combination of pills to prevent rejection, usually a 2 to 3 drug combination. You may have even been treated with some of these medications in the past for lupus kidney disease. Because these medications suppress your immune system to prevent your body from rejecting the kidney, you are at high risk for infection and cancer. In the first few months after transplant, you will also likely be on an antibiotic and an antiviral medication to prevent infection. Lupus kidney disease can come back after kidney transplant. However, this risk is small. In a study of almost 7,000 kidney transplant recipients, about 2% had lupus kidney disease after transplant. Although developing lupus kidney disease again after transplant increases the risk of the kidney failing, you are more likely to lose the kidney from rejection than you are from lupus kidney disease. Patients who are of non-Hispanic Black race, female, and less than 33 years old were noted to be at higher risk for lupus kidney disease recurrence. I want to mention something regarding pregnancy and lupus kidney disease. Lupus kidney disease increases the risk of complications during pregnancy for both mom and baby. These complications include preterm delivery, a condition called preeclampsia, small growth of the baby, worsened kidney function, pregnancy loss, and even death. There is increased risk that your lupus can flare during pregnancy. Also, many of the medications used for lupus kidney disease can cause birth defects. Because of this, I strongly recommend to my patients that if you are of childbearing age, you should use contraception. If you want to get pregnant, I urge my patients to discuss with their OBGYN and their kidney doctor and/or rheumatologist way before trying to conceive, so we can safely try to adjust medications and make sure your lupus kidney disease is under control.
Thank you, Dr. Wong, for sharing your expertise with us. And we hope that you, the viewers, got a lot out of this presentation. We are so excited to share it with you. Once again, a special thanks to our presenting sponsor, Aurinia Pharmaceuticals, for their generous support in making this and other educational videos in our Living Well with LN series possible. Thanks as well to our community sponsors, Blue Eyed Crow Studio, Tin Rocket, 7 Minute Cinemas, and Due North Studios. And as always, thank you for watching. We encourage you to visit our website, kaleidoscopefightinglupus.org, and follow our social media platforms for the latest lupus news, program information, award-winning blog articles, and so much more. Thanks for spending time with us, and remember, you are not alone. I'm Annika Hazlitt for Kaleidoscope Fighting Lupus. Please take care.